Hello, everyone, and thank you for joining us for episode 20 of season 5, Doc Talks with Dr. Forrest, Tennant, and Friends. We have a lot to go over tonight. Dr. Tennant, I'm going to go ahead and let you take it away. It's all yours. Thanks so much, Doc.
Thank you very much, Jamie. Tonight we're going to do something a little different. Tonight is going to be the night really dedicated to those people with adhesive arachnoiditis. That's where this show started. And the thing that's new about it is this handbook. This week, I published this handbook. It's on Amazon Kindle today, and it has in it everything I know. It's my latest, up-to-date, how you do it and how you treat things. So we're going to cover this handbook tonight, okay? Now, secondly, I see that we have Pat Irwin is here and some other people. I do want to call on her and Monty to say a few words about our advocacy program and our work with the medical boards. Also, I'm going to I do want to talk a little bit tonight about neuropathic pain. I've emphasized in the last few sessions that for people with constant pain, regardless of what it's due to, whether it's EDS, severe arthritis, RSD, arachnoiditis, head trauma, that you've got to treat three components: ascending pain, descending pain, and neuropathic pain. And particularly people with adhesive arachnoiditis have to be very well aware of neuropathic pain because it produces a very severe form of neuropathic pain. At any rate, what I want to do tonight and what I have done is that I have developed this handbook, and it's the second edition. I've revised it. It's the Handbook for Newly Diagnosed Cases of Adhesive Arachnoiditis, Steps for Treatment. Now, what I have done is written this handbook as if you're a new case, just diagnosed, and how you're to go about building a program. Now, this doesn't mean that somebody who hasn't had it for years can't benefit by what we're going to talk about tonight, but I did want to put it down to where it's a stepwise program which you take to your doctor and work with your doctor. Now, there is something rather different about this, and this is for the first time we are recommending that the starting protocol for adhesive arachnoiditis does not include corticosteroids or Toradol. We have developed a program to start without those compounds because the doctors don't like to use them. They do have side effects, and so we do have something new to talk about tonight, and that is for the first time in some 7 or 8 years, we are recommending that people start adhesive arachnoiditis treatment without corticosteroids or Toradol if they do the other things you have to do to treat this disease. Okay. Adhesive arachnoiditis, again, is still considered a pretty rare disease or an unusual disease. Most medical personnel still don't know what it is. They may have heard of it, but it's still quite unknown. Those of us watching this program certainly know about it, but I want to cover a couple of things about what it is and what it is not. Now, technically, it is a disease in which cauda-equina nerve roots are fused to the inner wall of the spinal canal cover, which is called the arachnoid membrane. And the fusion takes place due to inflammation and adhesions, they're like glue. Now, it's a very serious disease. In the 1800s, it was called the devil's disease. There was no treatment. People started to wither away, go to bed in terrible pain, and wither away and die without any hope. And of course, that's been the image of it in this country and in this century, or in the last century for most of it. And today that's different. We do have hope and we do have ways to control the disease. We can't cure it yet. It's like rheumatoid arthritis and lupus. We can't cure it, but we can control it to a great extent. Now, the other thing about adhesive arachnoiditis, it doesn't just show up. You just don't stand around and catch this disease. It is the end process of several events usually. Now, there are two great classes, people or causations, if you will. One group of causations are people who, unfortunately, are sometimes just standing around and have severe trauma to the spinal cord, not to the brain, but to the spinal cord itself. Now, these are people who are in an auto accident, may have had a severe fall, may have been, for example, in the military, injured in combat, in people in industrial accidents. A lot of time electrocution will cause this. So you do have a group of people who develop adhesive arachnoiditis because of direct impact, direct trauma to the lower spine. Most cases today, however, is that the adhesive arachnoiditis originates by some inflammatory autoimmune disease outside the spine that eventually takes in the spine. And prior to that time, they'll usually have developed other diseases like fibromyalgia, arthritis, neuropathies, arthropathies, and then finally they develop adhesive arachnoiditis. The initial symptoms may look a lot like Guillain-Barré syndrome or like multiple sclerosis. And in fact, those diseases and arachnoiditis are kind of kissing cousins because they all involve the spinal canal and they're all inflammatory diseases. Now, when we go through this on how you build a program and what you do for this, I would like everybody to think of one thing about adhesive arachnoiditis. It fundamentally becomes an inflammatory engine inside the spinal canal. In other words, in the lower spinal canal, something is causing inflammation to be persistent. It doesn't go away. It is there and it's just there. So how does it get there? Well, it's primarily an autoimmune process, but we now believe that the herpes class of viruses are very involved with this, just like herpes zoster causes shingles, other herpes zosters cause Bell's palsy, and some of the other herpes viruses, as you know, break out from time to time. The primary virus, we believe, is the Epstein-Barr virus. It's technically known as herpes number 4, but the cytomegalic virus, herpes 6, and some of the others, we do now believe become involved with the tissues inside the spinal canal, both by forming autoimmunity, meaning a process whereby inflammation keeps being formed, or we now have quite good evidence that these viruses live in nerve tissue. For example, it can live in the cauda equina, it can live in the glial cells of the brain, they can live in the arachnoid membrane. And so the protocol or the program for arachnoiditis has to take into account this inflammatory engine. And if you don't control this constant inflammation, then you deteriorate and you end up becoming paralyzed. Now, a couple of other things about arachnoiditis. There's about 21 nerve roots in the cauda equina, and those nerve roots attach to your feet, your ankle, your legs, your bowel, your intestine, your stomach, your sex organs, your bladder, and it also innervates your muscles in your legs and your buttocks and your feet, and therefore you can get a lot of symptoms. And if you don't control the inflammation and you don't control the disease, you can end up having a bladder that's paralyzed and have to live with a catheter. You may have paralysis of the legs and end up being bedbound. And so there's a lot of reasons to try to stop the deterioration. The stepwise program that we're recommending now is to stop deterioration. That's number one. Try to keep that inflammatory engine in check so you don't continue to deteriorate. Now, in the little book here, and it's written in nice big print, okay, easy to read, and it's written for lay people, and we're going to kind of take the steps that I recommend for somebody brand new. For example, there is not a week goes by that I don't hear about a case in which somebody just had an epidural and started developing symptoms, or if somebody just had a spinal tap and uh, uh, they've developed symptoms, or they've gone to their neurosurgeon or their orthopedist after 4 or 5 surgeries, and all of a sudden their new MRI comes back and says, you now have adhesive arachnoiditis. So the new cases tend to be those who have had several surgeries, or they're just coming off a spinal tap that went bad, or an epidural injection. And so where do they start? Most people are panicked. I get a panic case at least once a week. And so this was written for those people who started off in panic, so they've got a roadmap on how to go. So even though you may have had the disease a long time, just think of yourself. This book was written for that new case, but it's applicable to about everybody. And what's important, and what I do want you to know, this is what I know after I formed a Arachnoiditis Hope 8 years ago, and this is kind of my last best shot at it as to what I know and what I think you should do. Okay? Now, step 1 in the book, it says, keep doing what works. Okay? Now, everybody who develops arachnoiditis has this long history of medical problems, pain, surgeries, and you've probably found something that works. Maybe it's a muscle relaxant, maybe it's a rub-on, maybe it's a cane, maybe it's a pain medicine. Keep doing whatever you've been doing. The worst thing you can do is try to stop something that is working. You can take whatever works and build on it, okay? You can build on wherever you're at this time. So that's number 1. Number 2, put your medical records together, okay? Now, on this program, and I see we have Pat Irwin here and other people advocate things, but one of the best things you can do for yourself, particularly if you have a serious pain problem like RSD, small fiber neuropathy, or adhesive arachnoiditis, put together a hand carry set of records. Okay. Now, you may have started your adhesive arachnoiditis when you were a child because you had EDS. Okay. You may have had infectious mononucleosis when you were 18. These are important facts to put in your records. So you need fundamentally almost a lifetime record that you can hand carry. And also, we're recommending today that every person with adhesive arachnoiditis have a copy of their MRI. Now, you can see on the MRI where you have the nerve root clumping and where the inflammatory masses are. And it's important for you to know that, and to where you can walk in and show your doctor, you can show your pharmacist, you can show your caseworker, your insurance company. In other words, one of the things that doctors aren't going to do today, you're just not going to be able to walk in a doctor's office and say, I've got arachnoiditis, I've got small fiber neuropathy, I've got post-trauma headaches, and I need some opioids. That's not going to get you very far. As a matter of fact, it may get you thrown out and even labeled as a drug seeker. So you need a set of records. So put those records together. Also, try to figure out how you got here. What led up to you developing adhesive arachnoiditis? Like I say, you didn't just stand around and catch this. You've been sick for a long time. You fell off a roof. You had a domestic violence episode. You had something that triggered off autoimmunity, something that may have triggered off Epstein-Barr viral reactivation. Something happened in your past to bring you to the point that you've now got an inflammatory engine inside your spinal canal. So you want to put those together so you can educate your doctors, your nurses, your pharmacists, your family, and anyone else you come in contact with. You need to know your cause of all this, and you need to have your records. Okay. Now, the next thing we're going to start with is your diet. All right. Let's talk about the diet for adhesive arachnoiditis. Now, I'm not a great believer in having servings, counting ounces or calories. That's not what we need here. What we need in adhesive arachnoiditis is what I call the counterbalance. You've got an inflammatory engine eating away at your tissues. It's eating away at your arachnoid membrane. It's eating away at your cauda-equina nerves. And everybody who has adhesive arachnoiditis has discs that are deteriorating. That inflammatory engine is eating away at those. So what do you need? The big thing on a diet is that you're taking in enough amino acids to counter that if you can. Now, amino acids come from protein. So the diet that I recommend is a protein daily and anti-inflammatory fruit and vegetables. Okay? In other words, keep it pretty simple. But I do think that a lot of people are very confused about this. And what I'm going to do right now is you'll see a lot of writing today about what's called protein foods. Okay? Now, a protein food is a food that's got at least a 30% composite of protein. Okay? Now, and so here are the common ones. Okay, I'm not talking about uncommon ones like seaweed and some of these wild things, but common protein foods are as follows: beef, lamb, pork, poultry, like chicken, turkey, seafood, that's fish, shrimp, crabs, cottage cheese, and eggs. In other words, you don't have a lot of them, all right? And for example, most people can tolerate poultry. They can eat turkey or chicken without any trouble. Some of your fish products. A lot of people can't stand to eat protein. Now, if you can't stand to eat protein, I recommend you get you a supplement of amino acids, some kind of protein, some kind of capsules. But you've got to take protein into your body each day. Okay? Now, one other thing about this disease, and most diseases that cause severe pain, you lose your appetite and you lose a lot of your taste. So, I mean, let's face it, most people with adhesive arachnoiditis don't find cottage cheese very appealing. All right? Now, it's a great food, but you may not go for it. All right, and get you some amino acids from the health food store and take those. But you got to get some amino acids and protein into you each day to counterbalance that inflammatory engine I keep talking about. Now, you need some vegetables and fruits that may be anti-inflammatory. Now, I don't know how potent these vegetables and fruits are, but I can tell you that nutritionists believe in them. There's a general belief in the medical profession that certain fruits and vegetables have an anti-inflammatory effect, and you need to eat some of these each day. I'll read you off the list that's in the handbook: broccoli, green beans, leafy green spinach, lettuce or kale, peas, corn, blueberries, apples, oranges, pineapple, grapes, watermelon, cantaloupe. Now, there may be some others that are just as good, but the point is each day you need to take in some anti-inflammatory fruits and vegetables, and you got to take in some protein each day. So that's the simple way to look at a diet. Now, incidentally, there are a lot of people out here with AA that like the paleo diet. That's a form of a protein diet. A lot of people like to eliminate gluten. If you want to take pasta and bread out of your diet, be my guest. Okay. Now, you do want to keep the carbohydrates and sugars down. High sugars are not good because we think that viruses are involved in this process. And viruses love sugar, okay? And so we like for you to kind of keep the sugar stuff down. In other words, Diet Cokes, we're not going to sit around and talk about the hazards of the yellow or the blue packets. They're a whole lot better than eating plain sugar if you have this disease, okay? So you want to keep that, the pies and the cakes and the candies, the things we all love, you got to keep them somewhat restricted. Alcohol, you can have small amounts of alcohol. In other words, I want people to adjust to a diet that's practical, that you'll stick with every day. Eat a little protein, get some fruits and vegetables, keep your sugar down. You want to have a drink of alcohol once in a while, that's not a biggie. So that's kind of the simple diet. Keep it simple, because the key to controlling adhesive arachnoiditis is consistency, okay? You just can't do something here today on Thursday and skip it for 2 weeks and then do it again. I'm going to talk about exercises in a minute. There's an old saying, what's the best exercise? I'll tell you which one it is. It's the one you'll do every day, okay? Consistency is what this is all about. Okay, number 2, next step, hydration, all right? I recommend that people drink something every 2 hours, okay? Now, you don't have to keep a diary or anything, but you need to know that you've got to drink a lot of fluids with adhesive arachnoiditis. Now, why is that? It's for the spinal fluid, okay? The body makes about 500 milliliters of spinal fluid a day. Now, spinal fluid is a critical element in controlling adhesive arachnoiditis. Spinal fluid is made in the brain, and it's made by the fluids you drink, okay? You got to drink some fluids. So the brain can take that fluid, convert it into spinal fluid, and then the spinal fluid flows down your spinal canal, flows down on one side and comes back up the other. Now, why do you need spinal fluid? Spinal fluid is what controls inflammation. It carries out the inflammatory waste. It brings nutrients in to control it. It brings medicines in. As a matter of fact, you'll hear me talk a lot about this, not only tonight, but later. Drugs that you use to treat adhesive arachnoiditis have to cross the blood-brain barrier and enter the spinal fluid. And that's why our menu of drugs is not very long. They're very specific because they've got to get in the spinal fluid, because the spinal fluid has to carry the drug down to the lower part of the spine, okay? There is no blood vessels in the arachnoid membrane, so you've got to depend on spinal fluid, and you got to drink. In other words, you can't overdrink too many fluids. And I don't care whether that fluid is coffee, tea, water, sodas, but it's got to be some fluid, and you need to consciously try to drink something. Hydrate about every 2 hours, okay? So hydration, it's a bigger thing than we normally talk about. So, you're getting started with a little bit of diet and some hydration. Now I want to talk about a really serious issue with me. And I know I have a hard time convincing people, but there are a select small number of vitamins and minerals that I think everybody should be on, okay? And I'm going to give you the list that I think you should be taking. And then I'm going to tell you why you should be taking them. In fact, you might want to take some notes. In other words, if you ask me what medicine I take for adhesive arachnoiditis, it's not cortisone, it's not Toradol, it's vitamin C, okay? In other words, I'll stand by it. Vitamin C, 2,000 milligrams in the morning and 2,000 at night. You need 3,000 to 4,000 milligrams of vitamin C a day. You need some B12, 500 to 1,000 milligrams a day. You need vitamin D, 500 to 800 units a day. And then there are 4 minerals that can be very helpful: magnesium, selenium, zinc, and boron. Okay, now let me talk about why these vitamins. Okay, now there are now studies out that show that vitamin C and D and some of these minerals prevent the Epstein-Barr virus from reactivating. No, it doesn't. It's not 100%, but it does that. Also, the virus has a hard time living in tissues that have enough vitamin C and B12 and D. And those vitamins are also anti-inflammatory. Now, and on the minerals, let's talk about those. Magnesium, if you take magnesium threonate is the best because it's also a good pain reliever. It'll help whatever you're taking for pain. Selenium is known to be very anti-inflammatory and antiviral. Zinc is an old-time antiviral, and then boron is a new kid on the block. But I actually know some cases in which if they don't take their boron every day, they almost get a flare. Now, you don't have to take these minerals every day. You can alternate them. Take one day, maybe one another, but you do want to take these things. So as far as I'm concerned, these few vitamins and minerals are as important as any other medicine you take because they first off help control the virus, they help cut down inflammation, but they also help tissues grow. It's part of that counterbalance. You're trying to get your tissues to grow to counter the constant inflammatory engine that you have to put up with. So those are the specific vitamins and minerals. Now, we review cases at Arachnoiditis Hope almost every day. And you know, very few people are taking any of these vitamins and minerals, and yet they wonder why they're deteriorating. In other words, that would be my first recommendation. You want to stop deterioration, take these vitamins and minerals. They're cheap. You can get them in any health food store, and that they help the whole process of controlling this disease. Okay. In the book, step 7 is spinal fluid flow exercises. Now, it turns out that you can make this spinal fluid flow. We have a problem with adhesive arachnoiditis, and that is inside the spinal canal, you have these little micro clumps of the nerve endings of the cauda nerves are in clumps or masses, and they're glued to the wall of the spinal canal cover, and they entrap nerves. The nerves are entrapped right there, and I'm going to talk more about this because this is why certain pain relievers have to be used, because it's not only an inflammatory disease, it's a nerve root entrapment disease. Okay? Now, spinal fluid flow gets interrupted by these little masses. It's like having a big boulder in a creek. It interferes with the flow. And so these little masses inside the spinal canal give you things like headache, blurred vision, tinnitus, vertigo, dizziness, you're not stable. And so you get a lot of symptoms above the neck because of these little masses in your spinal canal interfering with the spinal flow going up and down the spinal canal. Now, you can do some exercises to help that out. And I'm going to read you some of the ones that I like. For example, if you just deep breathe, take in a deep breath and hold it for 15, 30 seconds, and then blow it out, that tends to move spinal fluid, okay? The spinal fluid doesn't have a pump like a heart. It moves up and down with your breathing, and if you take a nice deep breath and blow it out, you'll move spinal fluid. So that's the thing. Arm swings. When you walk and you're swinging with your arms, you're moving spinal fluid, okay? So these are 2 things that you can do several times a day. Walk or swing with your arms, and deep breathing. Now, the other thing that I really like is either rocking chair. You may recall that John F. Kennedy had adhesive arachnoiditis, we now know, after he died, and his doctors had him in a rocking chair every day, okay, in a swing. If you got an old-fashioned porch swing, that'll keep you going. So that's quite good also. And one of my favorites is just walking or gentle bouncing on a little trampoline. These things keep spinal fluid moving, and so I highly recommend these things. But if you don't have a rocking chair and you don't have a swing, you don't have a trampoline, just remember, swing those arms and take those deep breaths. It'll help. Every little bit helps in this disease. Next step. Okay, now here's one that's not going to be popular. You're to wear a back brace during waking hours. Okay. Now, nobody likes to wear a back brace, but if you've got adhesive arachnoiditis, you have got to wear a back brace during waking hours. Now, for several reasons, for 2 major reasons. One is you can't afford to stumble or trip or fall, because if you do, you may tear those entrapped nerves inside those little masses. You may tear the whole wall, tear the whole spinal canal cover, because you've got adhesions there. And so you just simply need to have the support to make sure you don't stumble, trip, or fall. That's the worst thing that can happen to someone with adhesive arachnoiditis. But there's a bigger reason why you want to wear the back brace. People with adhesive arachnoiditis have this inflammatory engine. I have yet to see zero, none, no one I've looked at the MRIs of over 2,000 cases of adhesive arachnoiditis. I've not seen one case in which they do not also have deteriorated discs. Okay, that goes with it. The discs are also inflamed, and those discs are pressing on the spinal canal cover and on the arachnoid membrane. That back support keeps you up straight, keeps the friction down. Okay, and particularly if you've got spondylolisthesis or scoliosis, you really need that back brace. And so when you're awake, you need it. My recommendation, go down to the sporting goods store, one of the major outlets. All the big pharmacies have them, Target, Walgreens, and get a nice soft back brace that you can put under your clothes and just make it part of your attire. Okay, keep it comfortable. I'm not a great fan of those that have the hard bits of metal in them or wood in them. Just something that is soft that you can wear and that you don't mind wearing. But over time, that back brace is very necessary. Now, I'll tell you one other thing. I've I've had many people. I've sort of told them, get that back brace or don't come back. Okay, get that back brace. Okay, and they got the back brace, and then they came back and said, doctor, my pain's a lot less. Remember, you're dealing with a tissue that is damaged in the lower spine, and that back brace keeps it stable to where it's not rubbing and you're not getting more and more friction and more inflammation. So that back brace, again, nobody likes to wear a back brace, but if you've got MRI documented adhesive arachnoiditis, that's part of your attire. And as long as you're awake, walking around, you need to be wearing a back brace. Okay. Next step, and this is not usually a problem, but every once in a while I see somebody with adhesive arachnoiditis wearing open sandals, wearing high heel shoes, loose slippers. You got to have a good tie-on shoe or a good snug slip-on. Okay, again, you don't dare fall, you don't trip, and so get good shoe support. All right, and again, that's a small thing, but it's to protect you and to also keep you walking straight and balanced. One exercise that isn't a bad one is just to stand there like a military stance, looking forward and nice and straight. It actually makes the spinal fluid straighten out. That's pretty good. Next thing, don't sit for over 30 minutes. Okay? Now, most people know this because if they've got adhesive arachnoiditis, the chances are they can't sit for over 30 minutes in one place. And that's because the most common area for the small micromasses is around L5 and S1, and that's right where you sit. And so you don't want to squash those little masses because you can damage yourself. And so 30 minutes is about as long as you want to be. Now, most people do this in daily life, except when they take a car trip or an airplane ride. If I've heard one story, I've heard it dozens of times, how somebody took a long car ride and hurt themselves, or a long airplane ride and hurt themselves. Even watching this podcast, it's going over 30 minutes. You need to stand up, stretch, and make sure that you stand up straight and walk around a little bit. You do not want to try to put pressure on those masses. So 30 minutes, and people take a car ride, just get out and stand up and walk around. Okay. The next thing I want to talk about are the exercises that you need. All right. And these exercises not only help the pain, but they also help the regeneration of nerves. The basic exercise for adhesive arachnoiditis is walking. Okay. Walking. Now, I love it when somebody is still able to walk 100 feet once or twice a day. That's great. But even if you have a hard time walking, at least walk 20 feet, 30 feet. But walking is lifeblood for adhesive arachnoiditis, okay? So walk whatever you can. Frankly, even if you're bedbound, try to move those legs like you're walking, okay? Now, besides walking, The other thing is just standing and what I call flexing and stretching. Okay, you want to keep it simple. In other words, the exercise where you just straight your hands straight up, you put your legs straight out, you raise your knee, you flex your ankle and your foot, but stretching and extending your arms and legs. Now, why the arms? The arms are hooked up to a muscles in your lower back, and when you raise your legs up, you're actually stretching your lower spine also. A lot of people don't realize that that's connected. So stretching your arms and your legs are very important. Okay, so extend and stretch. That's the name of the game. You bet. You can't fidget and you can't move your arms and legs too much with adhesive arachnoiditis. Now, another exercise that I really like is that I like weightlifting. Now, you need a weight should only be 2 pounds, maybe 5 pounds at the most. And whether you're doing curls or raising over your head or your arms, but lifting weights, 2 pounds, 3 to 5, no more than 5 pounds with each arm, again, is very helpful and very strengthening. So I recommend weightlifting. Okay. Okay. Next thing, you should identify some what I call topical pain relief measures. Now, what do I mean by that? A lot of people think that since this is a spinal problem, they shouldn't have to worry about doing anything with their back, but that's not really quite true. Now, the back muscles with adhesive arachnoiditis may go into spasm, and you may get a lot of pain around the spine for 2 or 3 reasons. One is adhesive arachnoiditis, unless you keep it well controlled, is going to seep through the dura and cause small seepage or leaks. And the spinal fluid outside the spinal canal is very irritating to tissues, and it hurts. So when your back hurts, it may be because you've got a small leakage, but it may also be that you're leaning to one side or another and you're in spasm. But one thing that I think everybody with adhesive arachnoiditis should do, and you should go down to the pharmacy and get some BioFreeze and some lidocaine, both, okay? And those are 2 things that freeze the nerves and might give you some relief. You also want to try some other things. They've got a lot of nice patches these days. Salotopus is one of them. Arnica, there's a lot of patches out there. There's a lot of rub-ons. The bottom line is you should try these things that are down at the pharmacy on your back and go from there. I also put in this category the use of these new devices, like they've got new TENS units. A lot of people are using, you know, different electromedical devices, ultrasounds, and I recommend all of those things. They may help, but you need to see if you can get relief in your back by rub-ons and by different patches on your back, because in flares you want to try to keep that under control. Okay, so you're going to work inside the spine and you're going to work on the outside also. Next remedy, water soaking each day. Okay. Now, when you use the term water soaking, what people automatically see in their mind is getting in a pool or a jacuzzi and soaking up to their neck. Well, that's one form of water soaking. But we like water soaking because water over the skin pulls out excess electricity. Inflammation or blocked nerves, like nerve entrapments with arachnoiditis, create a lot of electricity. And running just in a shower, running water over your back every day will actually eliminate a lot of electricity that's excess. And so we recommend water soaking. Now, if you've got a jacuzzi, you've got a pool, you've got a hot tub, hallelujah, take those soaks. They'll be very helpful to you. But if you don't, standing in the shower and letting the water run over your back works. A towel soaked in hot water is still darn good, okay? Also, a lot of people still get some good relief by soaking their feet. And there's nothing like old Epsom salts or some of the herbs to go in your foot bath, and they may help also. Remember that the reason why people like water soak and why it's been popular for centuries is that, number one, hot water relaxes muscles and increases the blood flow and helps healing. But number two, it also pulls out the excess electricity that causes pain. So again, try to take a hot shower each day and let it run over your back, or any other water soaking that you can do. Okay, now, the next thing that I'm recommending people do is, before you even see the doctor, or if you can't find a doctor, you don't have any medical help, start the 3-component medical protocol on your own, okay? And in the handbook, we've got the different non-prescription medicines that you, in each component, that you can use. And a lot of people today, despite all that's been written, don't like to do self-treatment. They think that I mean, there's not a day at our foundation we don't get somebody who asks the name of a doctor to go see. And most of these people are sitting around waiting to find a doctor before they start any treatment. That's wrong. The minute you know you've got a diagnosis of adhesive arachnoiditis, get started. And I'm hoping those of you out there who are going to be advocates and educators tell people, get some of these non-prescription things and get started. The idea is to try to stop the progression, slow down the inflammatory engine, get started. When you then find a doctor and you get some other help, that's great. But don't wait for the doctor to tell you what to do. Get started on your own. That's my message to you. In some countries, incidentally, our foundation has reviewed cases from over 60 countries around the world. And in some countries, you're on your own. You can't get a doctor. You're going to have to, treat yourself. And so what I've given people here in the book are my favorites to pick from. And so we're going to cover here. Now, the 3 components are, number 1, you want to reduce inflammation and autoimmunity. Number 2, you want to try to regenerate damaged nerve tissue. And number 3, pain relief. You want to go with those 3 components of the medical protocol. Okay, now, what I'm going to give you now are the 3 most popular anti-inflammatory agents that seem to be emerging right now for people with AA. And here they are: serapeptase, quercetin, and astragalus. Those 3. And again, I highly recommend get started with one of them. Okay. Now, regeneration of the damaged nerve. I recommend the first thing that you do is to try to get DHEA. All right. It's in every health food store, and the dosage is 100 to 200 milligrams a day. Now, what is DHEA? It's a big long name. It's dihydroepiandrosterone. Now, what does it do? It's a hormone made by the spinal cord for healing and neuroregeneration. And DHEA converts into testosterone, estrogen, progesterone, and maybe some other hormones. But it's also a healer, and you can't hurt yourself with it. And the dosage is 100 to 200 milligrams a day. And I highly recommend that that's a good place to start if you're an AA patient. Beyond that, it's a good place to start getting some regeneration of your nerves. Pain control. Now today, here's what I think every AA patient should be doing. And you need to get the compound called palmitoyl ethanolamide, abbreviated PHEA. We now know that is quite potent and helps with central pain as well as the spinal pain. The dosage is 300 or 600 milligrams twice a day. Okay. And you can get that started, and you can take that right on with whatever pain medicines your doctor might prescribe. But I am now a believer that people with AA should be on either 300 to 600 milligrams of PEA twice a day. And I think that's a basic pain reliever. In other words, to get started, you need one of the anti-inflammatory agents. You need a nerve regenerator, the DHEA, and then I now recommend that you get started with that PEA for pain. Okay. Now, once you've gone through all of these things, it's time to try to consult your doctor. Okay. In other words, you're going to need to go to your doctor, take all your records with you, and to see what the doctors can prescribe. Now, in the handbook, we have now put the starting protocol for doctors. Now, as I've said before, we've had a devil of a time trying to get the average doctor to prescribe Toradol or corticosteroids. Okay. And so we are recommending today that doctors start off with a new case with diclofenac for autoimmunity and inflammation, for regeneration of damaged nerves, medroxyprogesterone, and then whatever pain medicines that they like, whether it's naltrexone, buprenorphine, tapentadol, hydrocodone, whatever the doctor likes. And we've tried to outline this so that every general practitioner, every nurse practitioner will be able to look at this starting protocol and not be afraid of it. Okay, to where you can at least start trying to get it. One of my goals is to bring more doctors and nurse practitioners into the fold. Okay, now, if you start off with this little handbook and you go through all these steps, we recommend the doctors and the patients do an evaluation after 60 days. And after 60 days, if they're not doing well, they're going to need to go on the corticosteroids and the Toradol, okay, and maybe some other things. If they're doing well, they stay right with where they're at. And then also, we do want to start introducing to doctors the new protocols on trying to dissolve the adhesions. We've got a nice protocol worked out on that, as well as the anabolic hormones to try to regrow tissues with the peptides. And so we've got a lot of new things, but I've given you what I call the basics with that. Okay. I do encourage everybody to get the handbook. It's cheap. I think it's $13, something like that. But you should get it and have it handy and take advantage of it. Now, what I want to do now to close out the program, I want to shift gears and talk about what we call neuropathic pain. Okay. Now, in the past, I've talked about ascending pain and descending pain, and we're going to talk about neuropathic pain tonight. In other words, I want to talk about pain in this context. If you have constant pain, never goes away, you don't feel it, but you've got a combination of three different pains coming at you. All you know is that you hurt and you want relief. And that's just human nature. There's nothing wrong with that. But ascending pain is the electrical signals, the bioelectricity that's going from your point of injury or disease to the brain. It's going up the spinal cord. In other words, if you've got a bad knee, the signals are going to go from your knee onto your spinal cord. Or if you've got arachnoiditis, it's going to go from the bottom of the spinal cord to the brain. That's ascending pain. Now you have descending pain, and that is excess bioelectricity in the brain, and that bioelectricity is going to get sent down the spinal cord and down the vagus nerve. Okay. Now, to control ascending pain, the most common thing, of course, are opioids, and ketamine works, oxytocin, and there are some other things to control ascending pain. A lot of your antidepressants do some of that. For example, THC does. That's all based on ascending pain. Descending pain, you've got to have something that's called a norepinephrine receptor activator, and those are such things as Adderall, Ritalin, modafinil, phentermine, drugs that stimulate that particular receptor. Now, neuropathic pain is pain that is caused by an interruption of bioelectric conduction in the nerves. In other words, the nerve has a defect. It's either damaged or impaired somehow, so the bioelectricity will not pass, and it is backed up. Now, in adhesive arachnoiditis, the cauda-equina nerves are entrapped in an inflammatory mass. So it's about as bad a neuropathic pain as you can get because it won't let electricity pass. Now, there's a group of drugs that have been found that help that pass. Now, the first ones that were in America were a drug called Miltown. It goes clear back to the late 50s and early 60s. And then the drugs in the Valium class, the benzodiazepines, came along, and a drug called Soma came along. And those were, they didn't know why they worked. They were called muscle relaxants, but they were really conducting electricity in nerves that were impaired. Okay. Now, in later years here, they've tried to substitute with new drugs, and they go under such names as gabapentin, Lyrica, that's pregabalin and gabapentin, baclofen. Those are the major ones that are being used today. Your anti-seizure drugs like Topamax fall in that same category. Okay. Now, if you have almost all the major pain conditions today, you're going to need to have one of these compounds. Okay. But it's become very controversial. There's this movement to try to make sure that people don't take Soma or don't take a benzodiazepine, but go with one of the expensive new drugs, which probably aren't as good as the old ones. Okay. And so you need to be aware of that. But if you do have constant pain, you're going to need a neuropathic drug, as that's the new name for it. Okay. And in its real term, it just means bad nerve. Now, a couple of things that I do want you to know. We're having people being forced off their benzodiazepines, or they can't get good neuropathic pain treatment. There are some natural compounds that do help electricity conduct, and I'm going to give you the names of these. Kava is one, ashwagandha is one, valerian root is one. Those three herbal compounds you can buy over the counter, and if you can't get your Valium, or you can't get your Soma or your your Xanax or lorazepam, or if your gabapentin is making you sick, you may want to try these herbal compounds. But you are going to have some neuropathic agent if you've got severe constant pain. And as a matter of fact, to really control severe intractable constant pain, you're going to need a drug for ascending pain, a drug for descending pain, and a drug for neuropathic pain. And certainly we can help supply any more information about those things. I have a few minutes left. Is it possible that Pat Irwin or Monty could come on and say a few words about our advocacy with the medical boards?
Yes, sir. She actually had to leave a little bit early, but she left a message that she wanted to share with everyone.
Okay.
And Monty, you might be able to help me better with this. I don't know.
I'll give it a shot. What her homework assignment last week was just to do your own investigation in your states, get familiar with your boards.
Yes, I just found it, Monty.
Okay, good.
Thank you. Thank you so much. Yeah, she was saying to please review last week's video. And she wants things done by next week on the 26th, but to make sure that people put their name and initials and their state in the chat if they're willing to help with this. She said that's very important, and to please finish our action items. The action item is to look up your medical board website and see if they have opioid prescribing guidelines. And she wants that to be done by the next show on the 26th. Thank you, Monty. And if you have anything else to add, please feel free.
That's a great assignment. Okay. Yeah, let's all get behind this educating the medical boards. Okay. I got a feeling that very few of them know much about this problem, and I doubt that they know all the serious issues. So this is a great program. And next week that we're going to spend most of the time on this. Okay. Anything else, Monty?
No, I'm just saying it's been a very rewarding experience for me. And I give that young lady at the bottom of my screen, Kristen Ogden, credit. It was me listening to her speak at a board meeting about 2021 that got me involved. And we've developed a pretty darn good relationship with the board members now in the medical board in California, and we're making strides with the Board of Pharmacy. So we're trying to get the boards to work together, because all of these folks are impacted. The professionals that treat the patients are impacted. So we're trying to get them to work together. We're trying to build a coalition of the professional boards to try and help the pain patients and the physicians and the pharmacists.
Wonderful. It'll work. I'm convinced that if we just get out there and talk with them, we can bring about change. All right. With that, I think we're through. Jamie, I think we're finished for the evening. I've enjoyed it, and I hope that those of you have learned how to get a better program if you have AA. And we'll see you next week. And we'll focus a little more on advocacy next time as opposed to building your program this time. Good night. Have a good week. Bye-bye.
Thank you so very much, Dr. Tennant. And we all look forward to getting a copy of your new book. We look forward to that. That's such a great gift. Thank you for your time that you've spent with all of us. Everybody, you're not alone. You have a family here. Good night.
Good night.
Thank you all.
Thank
you.
Thank
Love
you.
y'all. God bless.
Good night, Pain Warriors.
Stay well till
Sorry
next
I was
week.
late. Hi, Valerie.
Internet connection.
Hey,
you,
Jamie.
guys.
Love you.
Love you.
God bless
Hi,
everyone.
Jamie.
Bless you all.
Good night.
Good job.
Thank you, Jamie.
Love you guys.
You're
all.
doing
I love
great.
you all. Thank you all. I love all of you.
Stay strong.
Love you.
Love you.
Use your
Hang in there,
stairs.
Dr.
Use your
Ibsen.
stairs. Just
God has us all.
Night, everyone. Love you.
Good night. Y'all have a good night.
Thank you, Brandon.
Carson.
Yes.
Oh, Carson, thank you.
Yeah, you're welcome.
And Brandon and Carson. Thank you, everyone. Good night. Thank you all so
Good
much.
night. Stay cool.
That's what they call a medical digest. They print out every quarterly.
Thank you all so much. See you soon.
So it's interesting to do that.
God save the Pain Warriors.
Yes. that's
Amen.
right. Amen. Thank you.